Welcome to Chapter 19, entitled Implementation of Pharmaceutical Care in Community Setting. Pharmaceutical care services in primary care have been an area of research from the initial definitions in the early 1990s. The research has resulted in a range of evidence-based services delivered in primary care setting, from the community pharmacies and by the pharmacy workforce. Research has also been focusing on the implementation in community pharmacy practice, taking into account the change in perception of the pharmacy that is needed to deliver pharmaceutical care services. In many countries, pharmaceutical care services are remunerated and to some extent are delivered to the public, although there is still an implementation gap between what is the potential of service delivery and what is actually delivered. The services are implemented in primary care, primarily delivered by the community pharmacy, confirming the role of the community pharmacy in the primary healthcare system. Next we will discuss the structure of community pharmacies. Community pharmacies are a significant part of the primary healthcare sector. Community pharmacies are often placed as independent entities where the public gets access without appointment to a healthcare professional. This is the only place in the healthcare system where it is possible to have direct access to healthcare advice. Other healthcare professionals, such as nurses or doctors, can only be reached through prior appointment. In many countries, the accessibility to community pharmacies is high. In 2015, Pharmaceutical Group of the European Union, abbreviated as PGEU, published the population to pharmacy ratio, which ranges from 1,200 inhabitants per pharmacy in Greece to 12,700 in Denmark. In some countries, this results in many small pharmacies in a city, and in other countries there are few large pharmacies serving a larger population. The practice in community pharmacies has been guided by core frameworks such as Good Pharmacy Practice, abbreviated as GPP. This ensures that the practice of pharmacy is delivered in a quality-assured and uniform way, for the benefit of the patient. The GPP framework has been developed by the World Health Organization, WHO, and International Pharmaceutical Federation, abbreviated as PHIP, over the years, and the latest version was published in 2011. Pharmacy practice is defined in Good Pharmacy Practice as the practice of pharmacy that responds to the needs of the people who use the pharmacist services to provide optimal, evidence-based care. To support this practice, it is essential that there be an established national framework of quality standards and guidelines. This definition is operationalized through the pharmacist's four roles in their daily work. 1. Prepare, obtain, store, secure, distribute, administer, dispense and dispose of medical products. 2. Provide effective medication therapy management. 3. Maintain and improve professional performance. 4. Contribute to improve effectiveness of the healthcare system and public health. The practice of pharmaceutical care is encompassed in roles 2 and 4, but it is also important to acknowledge that the fundamental of pharmacy practice originally consists in the activities listed in Role 1 in the Good Pharmacy Practice document. Next we will discuss workforce in community pharmacies. The workforce and roles distribution within the composition of the pharmacy may vary by country, depending on legislation, the availability of pharmacists and the structure of the pharmacy system in the individual countries. In pharmacies, the two primary categories of professionals are pharmacists and pharmacy technicians. On average, there are 1 to 18 pharmacists per pharmacy according to PGEU's Annual Report 2015. In some countries, there are also bachelors of pharmacy employed at the pharmacy. Internationally, there appears to be an overall shortage of trained pharmacists, which means that, in some areas of the developed countries, the distribution of medicines and the counseling on medicines are undertaken by pharmacy technicians or non-trained personnel. The individual practice is regulated by national legislation, and in settings with a shortage of pharmacists and pharmacy technicians, the non-trained personnel can work under supervision of pharmacist. Trained personnel in pharmacies is specialized in medicines, in compounding medicines, and, to some extent, in counseling on medicines. From country to country, there is a great diversity in the training. Only a limited number of universities have focused on the structure of the curricula to systematically support the delivery of pharmaceutical care services. The FIP education, abbreviated as FIPED, published a report on what is required currently, and in the future, to educate pharmacists to take on the responsibility for good pharmacy practice and pharmaceutical care. The FIP also published a set of development goals for the pharmaceutical workforce. These goals are inspired by the FIP needs-based educational model that addresses the process of building capacity in the pharmaceutical workforce based on needs, services, competencies and education, as shown in Figure 19.1. The model works from the perspective that the design of the pharmaceutical workforce education should be based on local needs and the health of the population. According to the model, the workforce would be socially accountable to the national healthcare system, and should enhance global connection for a quality-assured workforce that will take care of national needs. In Table 19.1, the pharmaceutical workforce development goals produced by FIPED are presented. They are divided into clusters focusing on academy, professional development and systems. Each cluster has a set of individual goals with a short description of what is included in the individual goals. Besides the pharmaceutical workforce development goals presented above, the delivery of pharmaceutical care also needs a different set of competencies within the pharmacy. Research from Australia has focused on the work of implementing pharmaceutical care. See Section 5.1. Alison Roberts and L. Folletto's PhD thesis particularly showed that the focus for new practice should be change management within the pharmacies. It acknowledged that delivery of pharmaceutical care services should follow a strategic decision taken by the pharmacy owner, taking into account how the pharmacy can build organizational flexibility. The pharmacy should consider strategic, business and financial planning of the delivery of services, and it should address the image of the pharmacy, secure staff management and consider external support and resources. Pause the video and carefully scrutinize Figure 19.1 illustrating the FIP needs-based educational model before advancing to the next slide. Pause the video and carefully scrutinize Table 19.1 summarizing the pharmaceutical workforce development goals, also referred to as FIPED, before advancing to the next slide. Pause the video and carefully scrutinize Table 19.1 summarizing the pharmaceutical workforce development goals, also referred to as FIPED, before advancing to the next slide. Pause the video and carefully scrutinize Table 19.1 summarizing the pharmaceutical workforce development goals, also referred to as FIPED, before advancing to the next slide. We will now look at independent pharmacies and chain pharmacies. Historically, the community pharmacy sector has been highly regulated by official bodies. This is both to ensure that the medicines purchased in a pharmacy are of the expected quality, and because, in most countries, governments subsidize medicines. Therefore, community pharmacies in many countries have the exclusivity of prescription-only medicines dispensing. The practice involves both the compounding and the dispensing of medicines. In many countries, pharmacies are individually owned by a pharmacist. However, this situation has changed over the past 50 years, and many countries have deregulated their systems and liberalized the community pharmacy sector. There are different models of liberalization, but in all systems, the overall responsibility for good pharmacy practice in community pharmacy remains with the pharmacist. Community pharmacies are, at a national level, often organized in a pharmacy organization. This organization has the task of carrying out the best interest of the community pharmacy sector, and is often the collaboration with government regarding negotiations and legislation in the community pharmacy area. Supporting the delivery of pharmaceutical care services, at a systems level, would also be the task of the professional organization. This can be done through structures for delivery of services, such as manuals and instructions for services, and supporting building capacity to deliver services. A 2011 report based on a European survey, and illustrated by case studies, showed that in liberalized systems, the trend goes toward an increasing number of pharmacies, mainly in the metropolitan areas, not in the rural areas. It also shows that pharmacy is still the preferred place to purchase medicines, including over-the-counter, abbreviated as OTC, medicines that are otherwise also available in retail shops. In countries where pharmacist ownership is no longer required, the opportunity for commercial chain pharmacies has opened up. There are both national and international commercial pharmacy chains. Looking at the practice of pharmaceutical care in commercial pharmacy chains, the focus in the chains is typically commercial. If the chains take up the delivery of pharmaceutical care services, they are professional and conscious about the commercial delivery of services in their approach, and often succeed in implementing services from a financial perspective. Mail-order pharmacies have over the years been available in USA, and one of the more recent developments are online pharmacies. These entities secure the distribution of medicines to areas with low population density. Next we will address the question, what works? The development of pharmaceutical care and the focus of pharmaceutical care services are shown in Figure 19.2. It shows how research has moved from solely focusing on producing evidence for services to implementing services, acknowledging that the delivery of services and change management in the pharmacy is a discipline in itself. Looking back at the pharmaceutical care research, different angles can be considered to see how it has evolved over the years. In the early 1990s, the focus on pharmaceutical care was moving in two directions, from the development and later patient outcome-oriented approach to the development of services that could be delivered by a pharmacy. And the focus on pharmaceutical care was a strategy for the profession. The research area needed both the development of evidence-based services and the focus on the pharmacy as an organization that should change practice to reach the state of practice where we are today. The research on developing pharmaceutical care services concentrated on where the focus was in the services, and who should be the target group for the services. This led to a distinction between population, risk patient and individual patients with chronic disease. In the early days, the services were mostly developed to be delivered directly to the patients, while later research showed the development of services delivered to other primary healthcare professionals, in order to allow them to support the implementation of safe and effective medicines, e.g. among elderly in nursing homes. See Chapter 20. Pause the video and carefully scrutinize Figure 19.2 illustrating the development of pharmaceutical care research and practice, presented at Pharmaceutical Care Network Europe Working Conference 2013 before advancing to the next slide. And now we will discuss pharmaceutical care in community pharmacies. In community pharmacies, the implementation of pharmaceutical care has been attempted using different initiatives and activities. In many countries today, it is expected that when patients come to a pharmacy they will be counseled on their medicine use and self-management. This may or may not include checking drug-related problems and hence involve basic pharmaceutical care at population level. In some countries, the pharmacies are bound to report medication errors to authorities. E.g. in Denmark, side effects reported by patients or observed by pharmacy staff will be reported to the Danish Medicines Agency. Pharmaceutical care has also been translated into being the delivery of health services from the pharmacy. Many services have been developed and implemented over the past years. These services are mostly oriented toward better self-management or a safe and effective implementation of medicine treatment. Figure 19.3 shows the different target groups for pharmaceutical care. At population level, pharmaceutical care can be seen as the general role the community pharmacy has in health promotion and disease prevention. This can be done through campaigns both at the individual pharmacy and in collaboration with other healthcare professionals in primary care. An example of this could be the role of community pharmacies in immunization programs. Moving from the general level to the specific level addresses patients at risk. These patients are at greater risk of experiencing medicine-related problems due to specific risk factors. They could be elderly patients, with comorbidity or low renal function. It could be patients with low health literacy, having difficulties in understanding the information on their treatment, or other patients at risk for not gaining the full potential of their treatment. Pause the video and carefully scrutinize Figure 19.3, illustrating different target groups of pharmaceutical care before advancing to the next slide. Finally, there are disease-specific programs, addressing a patient with a specific disease. Often this area is founded on evidence-based programs documenting the effect on patient outcomes when they receive pharmaceutical care services in the pharmacy. Pharmaceutical care is care for a patient who uses pharmaceuticals. Therefore, the services should involve the persons who have responsibility for the patient's medicine therapy. This might be the patient himself, an informal caregiver, the staff in a nursing home, or the general practitioner. They will all gain knowledge by getting support from pharmacists in the delivery of safe and effective medicines management to the patient. Figure 19.4 shows the services delivered and remunerated from community pharmacy at an international level. The services are divided into services for improving the use of medicines, product-focused services, primary care and public health services, harm reduction services and other services. The services that improve the use of medicines are focused on the implementation of rational pharmacotherapy through medication use review, medication reconciliation and new medicines services. Additionally, there are more comprehensive programs on the known chronic diseases, diabetes, hypertension, asthma and cardiovascular management. Medication review has been introduced in many countries as a core service in community pharmacies, both in a nursing home setting, in general practice and directly to patients. The service is always delivered by a pharmacist and includes a structured review of the medicines, addressing medicine-related problems and proposing solutions to the problem. Many studies on outcomes have been completed, and it has been documented that the delivery of medication reviews made by community pharmacists can improve patients' quality of life and improve patients' empowerment and health status, thus decreasing the number of contacts to the healthcare system, and thereby reducing healthcare costs. For further information regarding the delivery of services internationally, see chapters 13 to 17. Pause the video and carefully scrutinize Figure 19.4 illustrating services pharmacies provide and are remunerated for before advancing to the next slide. Next we will discuss pharmaceutical care in general practice. Medicines management performed by independent pharmacists in general practice has been tested in different models where pharmacists support general practitioners in their responsibility for the patient's medicine treatment. The studies have proven positive results on risk groups such as elderly polypharmacy patients. This is implemented in practice today in UK and supports the outcomes of the patients regarding medicines management. Different models for pharmacist prescribing support the overall care for the use of medicines at population level and secures accessibility of the medicines. Next we will discuss the future of pharmaceutical care delivery. Over the years, dispensing medicines and performing pharmaceutical care have been united at the pharmacy, personalized by the pharmacy workforce. In the future, this may be challenged. E-pharmacies and other web-based shops can distribute medicines, and they can be delivered by drones. In Switzerland, drones are already applied in the hospital setting, for safe delivery of test responses. This will challenge the professional counseling regarding medicines as we know it today, because the physical meeting for counseling the patient is separated from the dispensing of medicines. This will call for new models for counseling, new pharmaceutical care services and yet new roles for the pharmacist. Darren Baines, a health economist from UK, focused on healthcare and in particular the history of pharmacy and pharmacists. He believes in the profession, stating that pharmacists have always worked with technologies in their practice. In the production of medicines over the centuries, the pharmacist and the pharmacy have been the place where patients go for treatment and the profession they trust to advise them about medicines. To retain this role, pharmacies should rethink their approach to practice. He states 5 steps to have technology-enabled pharmacies in the future. 1. Refit the front of the house as a technology hub that allows patients to connect with the pharmacy, local doctors, the healthcare system, pharmaceutical companies, charities, other patients and the like. 2. Exploit the time that the patients wait for their prescriptions by connecting them to a technology-enabled task, such as reporting on their medicine use, watching an interactive educational program, completing a questionnaire or being an expert patient in a study. 3. Network the pharmacy hub into the wider healthcare community, including providers, patient groups and private companies, and by doing so, become the port of first call for patients, and coordinate their care through the pharmacy's technology-enabled networks. 4. Retrain pharmacists in healthcare technology, not just medicines optimization. 5. Educate and enable the public to become technology-enabled pharmacy users. The future comprises new platforms for communication, new data to be included in models and new expectations from the patients. The patients will expect availability round the clock, and they will expect the pharmacy to honor this need. Pharmaceutical care services in the future have to honor these needs to be relevant for the patient. Thank you.